Hey folks, I'm Dr. Jeff Williams with Creekstone Integrated Care right here in Amarillo, Texas. So this week, I wanted to discuss a question I've asked myself over the years, and that is, this patient has a low back disc herniation of about 4 millimeters or whatever it might be. They've got that when they're laying down in a tube doing an MRI, but what happens to that disc when a person sits up or bends over and starts bearing weight? Now that's a valid question when you consider that I've seen patients with classic disc signs, including radiculopathy into 1 or more feet. Now understand that a general rule with radiculopathy is that the further beyond the knee it extends, the more likely it is to be a disc that's causing the problem. In these patients, when you have several other orthopedic signs that are pointing to a disc, well, you'd reasonably expect a mild to moderate or possibly a severe disc bulge when the MRI comes back. But I'm here to tell you, it doesn't always go that way. So again, I find myself asking that same question. The disc can be kind of like a really strong bag of water. If I lean in one direction, I'll push the bulk of the water in the opposite direction, and vice versa. Also consider that the most pressure you can put on your low back is to be in the seated position or seated and bending forward. What exactly do these positions and loads do to the disc that's already at, say, a 4 millimeter bulge when a person's just simply lying down without bearing any weight on it? Well, what do we do when we have questions? We turn to research, and thank goodness I'm not the only one that felt this was an important question to get figured out. As a matter of fact, I found so many research papers on this topic, I'm going to have to break this discussion and the blogs on our website into separate parts so we can make it easier to digest and not quite so boring. So here goes part 1. We'll start by a study by Nguyen et al. Called Upright Magnetic Resonance Imaging of the Lumbar Spine, Back and Pain Radiculopathy. Now here's why they did it. While low back pain and pain into the legs or numbness and tingling into the legs, they may be somewhat common, many times the findings on the MRI, they don't show what we would expect to see. The authors of the study wanted to find out what difference there would be in a supine or lying down face up MRI versus an MRI performed with the patient in a seated position and bearing weight, or what you would call axially loaded. Now here's how they did it. There were a total of 17 participants. 10 of the participants were asymptomatic, not having issues. 7 of the participants were symptomatic. Upright MRI was done on each adult while they were in the seated position. Measurements were performed from the 2nd and 3rd lumbar level, another way of saying that is the area that is beginning the low back, the top of the low back essentially. They measured from there down to the 5th lumbar and tailbone region, or your lower back. There were also measurements of the areas that the nerves of the low back pass through so that they could determine the various sizes of these holes. And these holes are also known as foramen. Now here's what they found. Mid-disc width accounted for 56% of the maximum foramen within the symptomatic group. Mid-disc width was over 63% of the maximum foramen within the asymptomatic volunteers. Disc bulging was 48% larger in the symptomatic group, and the measurements of the foramen were smaller in the symptomatic group. So let's wrap it up. What does all that mean? The information suggests that MRIs performed in the upright seated position can be useful in the diagnosis process because it's better able to distinguish important differences among the asymptomatic and the symptomatic, especially when you're talking about the size of the intervertebral foramen, or the holes the nerves pass through. In another study by Madsen et al., while the authors argue that axial loading of the spine doesn't necessarily cause any significant changes to the disc itself, the simple act of having more extension in the spine was a determining factor as to how much space remained in the dural sac that surrounds the spinal cord, or the cauda equina. Now I want to be fair, so I'm including this study. It's just the disc play a very small part in the process. But as you'll see from about 10 other papers we're going to discuss in this series, this sort of finding or thought, it's pretty much in the minority. It's not a very common thought. In yet another similar study by Hansen et al., the authors were testing similar parameters in the cases of diagnosed stenosis patients. Now here's why they did it. Protrusion of a disc has commonly been cited as the cause of symptoms from nerve root compression in patients with stenosis when the spine was axially loaded or weight-bearing. They were interested in determining whether it is the disc or the ligamentum flavum that caused the difference when loaded. Now here's a quick diagram of what we're talking about as far as the anatomy. Now, here's how they did it. There were 24 participants in the study. The spines were examined by MRI while laying down supine, also that's called face up. So then the study was repeated with roughly half of their weight loaded to the spine axially. The measurements were through the cross-sectional areas of the spinal canal, as well as the ligamentum flavum, the thickness of the ligamentum flavum, the posterior bulge of the discs, and the intervertebral angle. Now say all of that 3 times and see what happens. So here's what they found. The axial loading did in fact decrease the cross-sectional size of the spinal canal. In other words, it took it from this to this. Increased bulge or thickening of the ligamentum flavum was to blame for 50% to 85% of the decrease in the spinal canal size. Now to wrap it up, the authors concluded that it appears the ligamentum flavum, not the disc, played a dominant role in reducing the size of the spinal canal or the loaded spines for those with stenosis. All right, so those are the 3 we're going to cover right here. That's going to wrap it up for this week. We're going to continue with part 2 next week, so please join us for that. I hope you're learning something here. We're scratching the surface, but when interpreting your low back MRIs, keep in mind that unless you had a weight-bearing MRI, you may not be getting the whole story. Be sure to subscribe to our YouTube channel, share us on Facebook and social media, and let everybody know all about us. Again, I'm Dr. Jeff Williams, Creekstone Integrated Care, right here in Amarillo, Texas. Thanks.